I had a friend who was very ill with a complex disease, and I asked a person who happened to be around. This person was white, wealthy, very, very wealthy CEO, and said, you immediately need to have this person either move to Minneapolis for Mayo Clinic, or move to Cambridge and Boston, or move to Baltimore for Hopkins. And I thought about that in opening this up on Access. Why doesn't that encouragement to move to Baltimore work for everyone here? Lisa?
Yeah, that's a really, really important question. And I think a lot of people in Baltimore ask that very same question. Why is it that we live so close to one of the, probably the largest and one of the most prominent medical institutions in the country, but yet people in our neighborhoods are dying and
so you're there and you work in that little nice place. So how can you fix it? Yeah.
So I mean, I'm working to fix it. It's obviously, you've heard a lot about how these problems are caused by a number of different factors. So there are things that are out in the environment, like environmental exposures, housing, economic situations. All of those things contribute to health, and we've heard a lot about the fact that health care probably is only 10% of what makes us healthy, but it is an important 10%.
Right.
And the reason being that having access to that care allows you to prevent illness. It allows you to learn about what it takes to be healthy, right? And so it's our responsibility when people come to us to make sure that they get the care that they're supposed to get, and to bring all that expertise and all that wisdom that we have and make sure that it gets to people, but not to wait until they come to us.
Yeah, I know there are a lot of stakeholders in the room. I've loved meeting so many of you out there, and thank you for all of you being here and everything you do. But what do you, we were just talking, Lisa, about what can be done to strengthen the bridge in partnerships with those stakeholders in the community on community health, and particularly on the access question. What are the tricks you've learned that would be healthy, that this room would benefit from in terms of enhancing that partnership so that we go from 1 to 10 fast?
Right. Well, one of the things I've learned as a physician and then also as a researcher is the importance of actually just listening to people, to really being there to witness whatever it is, the suffering that they're going through or the challenges they're facing. And sometimes, even if you can't fix the problem right away, just being there to be the person that acknowledges that this is wrong and that you shouldn't be going through this is a big part of the issue. So with being a physician in that one-to-one relationship with a patient, that's important. And then also with being a researcher who's community engaged is going out to communities, trying to engage with people who are running community-based organizations. I see some of my community partners out in the audience, going to where they are, learning about the struggles they're facing and the clients they're trying to serve and support, and not necessarily starting out by, offering whatever wonderful expertise I have, but just being there to witness and listen to what the issues are and learn about what brought people to the place they are right now, and what they think some of the answers are. So I think listening respectfully, taking the time, because it takes a long time, and don't expect that everyone's going to trust you and want to work with you and want to, do whatever it is you're recommending to them right away. They may not want to join your study. They may not want to take that medication that you're prescribing to them. But understanding that relationships take time. A lot of people have talked about relationships here, People need to know that you're committed to them for the long haul and that you're not just here just for this particular project or, for this one encounter, but you're going to be there.
So John, like Lisa, I should mention that, Lisa and her work have been commended by the MacArthur Foundation. You were a MacArthur genius, which is kind of a cool thing in my world. You're a MacArthur genius.
John.
Yeah. We got two MacArthur. I've never been on stage with two MacArthur geniuses at the same time. Garth?
Oh, man.
I'd say you're next, but we'll get to that later.
Ours so
but John, you've written powerfully also about reaching communities, particularly young Black men where they are, the trauma that they have experienced in their daily lives, just in terms of being who they are, and in terms of reaching out and thinking holistically about health and community and being, what are the things we're missing that we don't get that we should?
Sure. One of the things I think we're missing, I think Lisa talked about this, is that there's a narrative that people carry around with them that this is their fault. And it is very true for young people who come in who are victims of violence, that if they've been shot or stabbed or assaulted, that in the medical context or in the law enforcement context, they're made to feel as though it's their fault. And so part of what we have to do from a healthcare perspective is to acknowledge that that is a false and a destructive narrative. And we have to acknowledge that the conditions, the institutional racism that underlies many of the challenges that our patients bring in is the thing that we have to name. So that in healthcare, if we treat young people as though we're agnostic to the existence of racism, then we don't have the ability to connect. And because, particularly for young Black men, they are so highly stigmatized and thought of in such negative ways, we fail to see the potential in them to be a part of the work that we're doing. So much of our work has been dedicated to providing the support for young people to become community health workers and peers in the community, because they are more effective than we are in our healthcare perspective, because they're able to engage young people who haven't engaged with the healthcare system because they don't trust it, and they don't trust it for some very good reasons.
So you were in Boston for a long time. You're in Philly now. How did you, like, give us some stories here? How did you move the needle on this subject in Boston with young people feeling they were to blame for their own health challenges?
Well, first, I think that many of us who have practiced in urban environments are often one of a handful of people of color who are physicians in that setting. And so in moving about Boston City Hospital, I was keenly aware of the fact that they were being treated in a different way. And it was often true that in the midst of the healthcare debate in the early 90s, which many of you don't remember, I would go to meetings and we would talk about primary care for everyone. And then I would raise the issue of young men of color or young men, and somebody would say, oh yeah, violence prevention. I was like, well, how did we get from primary care to violence prevention,
yeah.
right? So the only thing, the notion that all these young people needed was violence prevention.
Did your head explode? Or were
Not
you calm?
immediately.
Yeah.
Not then. But I think what we were able to do is to say, well, what if we create an opportunity within primary care that's focused on young men, that meets their needs rather than assuming that we know what they want? And that actually requires that we have a diverse workforce of providers. And one of the most shocking statistics now is that there were more Black male medical matriculants in medical school in 1978 than there were in 2014. So this is where we see institutional racism playing out. It is not only the issues that affect young people in the inner city who've been victims of violence, but we're also seeing the weathering effects of this kind of sort of institutional racism affecting the workforce in terms of the diversity.
Lisa, what's the diversity like in Hopkins? Is it better than that, or is it pretty crappy too?
So I think, we have diversity among our medical students that we've been working on, and that's increased,
From like 2% to 4%?
Well, no, I
like,
would say more along the lines of like 12 to 15%. I'm thinking of like African Americans and Hispanics, so people who are from underrepresented groups in medicine. So not necessarily Asian Americans are not underrepresented in medicine, so
Right.
they may not be included in that proportion. What happens is when you go from medical school to residency and then to faculty positions, that's where you see the numbers really drop off. So we have less than 5% of our faculty are from underrepresented ethnic minority groups.
So Garth, if you're not a genius and you have money, that works, So you're the foundation, right? So Aetna Foundation.
Oh, I feel important.
I'm going to ask you this seriously. I had an opportunity to go into the archives of the Rockefeller Foundation. Many of you know the Rockefeller Foundation has been around a little bit more than 100 years, and the Rockefeller Foundation really created the study of public health, the schools of public health, not only around the United States, but around the country. And it was interesting to look at why the institution decided to commit to this and so I guess with Aetna, I always intrigued with people that have resources to try to shape and sculpt what opportunities are. 100 years from now, what will you have wanted us to see that you built that we haven't built today?
Sure. So, two things. I think one of the things we recognize is all healthcare is local. And if there is one thing we would like to see is local communities empowered to make the change that they need to make. And I'll tell you something about these two geniuses sitting up here. I've known both of them, and I've known John when I was about this high, before he was a MacArthur genius. And what I learned from John, not that you weren't a genius before, was you have to be in the community.
Yeah.
And so part of our efforts is to be as local as possible, to empower people to make the decisions. We don't want folks to do the things we want to do. We want to help them to do what they want to do. And so if there is a legacy that we would like to leave, it would be that there would be local communities that are empowered to make change. The challenges that are faced in Baltimore are deep, but they're reflective of the challenges faced in many urban communities. The solutions may be unique to Baltimore because there are a group of partners, a group of assets here, and asset-based solutions is what we're interested in. And so I think from my perspective, and I think what I'd say I've learned from my mentors before, is that we want to leave a legacy of local change that's been inspired by the folks in local communities.
What do you think, I mean, in terms of concrete things that you've seen other communities, because you're all over.
Yeah.
But I'm always interested in show and tell.
Yeah.
So show and tell elsewhere, what are practices that may not have been on the radar screen or the dashboard of options here that you think are cool that we may not be talking about today?
So there's some interesting things that we've seen where local communities have provided them, have served as a source for healthy food options. And at the 10,000-foot level, when you see some of those things happening, it's inspiring because many times we see there's a guy by the name of Tony Hillary who runs Harlem Gardens. And it's not just the fact that they're producing healthy food, it's the fact that they're economically building up assets within the local communities by training these young African-American men how to get involved, think like businessmen, and then give them the social and economic stature to be able to make a difference. I'll tell you, that means something to me personally, because the transformative thing for us in terms of my family that brought us from where we were to where we are was education, and having us me particularly being aware of the kind of opportunities that I could be. And so these things that the Harlem example and others that we see is not just about, again, providing fresh fruits and vegetables locally, but this idea that you empower local communities to make decisions that then give them the assets to be who they want to be. And that's kind of change we'd like to see.
John, Lisa, we haven't gotten a lot into the political world. Maybe that's a good thing. But, I'm just sort of, as I think about all the good work you guys are doing, does the toxicity right now around issues of race nationally, what's going on, does that affect our ability to get to successful outcomes? Are you guys feeling it, or is it something that is happening at a level that doesn't matter, that along what Garth says, hey, local level can, still make progress? I'm just wondering if anything in Washington matters right now.
So, well, yeah, it definitely matters. I mean, I think we do feel it. I think, in some ways we're insulated because we are around people who are more like-minded a lot of the times. But we feel it because we know that without the support of policymakers on a larger level, that it's hard for us to actually make progress on changing some of these structural issues. We can empower individual people, we can work with local organizations, and we should continue to do that. I think what's difficult about the larger dialogue that's going on nationally is that, it does create this sort of sense of frustration, and you can get hopeless about it if you really focused on that. But I think what we have to remember is that the solutions are not dependent on those larger issues. We have to start where we are, and then maybe figure out a way that we can talk to those other people that aren't seeing things the way we are.
Hey, John?
I think we feel it in the way that it's sort of like there's pollution out there, we all breathe it, But when the volume gets turned up in this way, it's like smog. You can both see it and breathe it. And it's the kind of toxicity that we actually see in the experiences and in the trauma of the young people that we're working with. So I think that there is, on the other hand, there has been, I think, more mobilization where people are now talking about issues of race. And while the conversation seems more polemic and fractious in many ways, to some extent is what I was saying earlier, to acknowledge that it is an issue and that it is an issue for the health of all of us. And I think health care and public health have begun to talk more boldly about this. I think we're going to get to a place where it actually yields us benefits because we're talking about it. But in the short run, I think for many communities, it has been dispiriting. And so we can't walk away from the reality that is now sort of more evident before us.
I want to go to the audience in just a moment, but I want to ask Garth and all of you just short form, what's the best city in the country in terms of achieving literacy in communities that are traditionally left out of the healthy healthcare track, and what's the worst city?
So I think what we see is pockets of success in many local communities. We see churches here in Baltimore that have rallied and transformed communities. We see things in North Carolina with some churches that we're working with in Mecklenburg, North Carolina.
So you put those on the up, the good.
I put all of those on the up and the good. I put
And
those
what's the
kinds of
crappiest?
efforts. So I think, where we see some of the most challenges is where the infrastructure, whether it be the government, private sector, have not rallied to support the communities as much as they should. And so part of what, I think we see that everywhere. We see that in the pockets everywhere because, again, all healthcare is local. So even going from one zip code to the next, within in a particular city, in Boston being a perfect example, you can go down the red line and go about 30 years in life expectancy. So there are challenges within cities, but what we see is pockets of success within that. Let me add one thing. John alluded to this earlier. 20 years ago, I saw John go into some of the most entrenched communities in Roxbury. And one of the young African-American men I remember was reflecting on one thing. A lot of these communities, they're not looking on us to come and save them. They know what their solutions are. We need to enable them to make this change. But part of what we need to do is to, again, build the assets so that people can make the decisions that they want to make.
Thank you. Lisa, best and worst?
Best and worst. Well, I agree with Garth. I think that we have smaller communities that are doing great things. I understand, I know leadership is really important in New Orleans. I know there's leadership there that has transformed the educational system there. And so you see that, communities have now gotten more mobilized and there's more focus and attention on addressing health inequities. I think Baltimore is a great place. I think we talk about the problems here, but we actually have a lot of wonderful things that are happening right here in Baltimore.
Thank you. John?
So I'm not sure I can name names. I would say that
You can.
Well, let me tell you, every place, you've got to be careful when you're patting yourself too heavily on the back about this, because to the extent that, again, institutional racism is entrenched, if you're naming it as a health issue, if in a way you're thinking both about health in all policies, but equity in all policies, then you're moving in a direction. So I saw in Boston the ability to articulate within the health department, we're undoing racism. We're going to make that one of our objectives. So to the extent that cities aren't naming that as one of their key objectives, then I think they're going to fall behind.
I agree. If I were to answer my own question, I would think most cities have both good and bad. So I generally agree totally with what you said. Let me open up. Yes, we've got a question here somewhere in the middle. I see someone. Hi. Good morning.
Hi. My name's Kelsey Reese. I am a medical anthropologist with Charm City Care Connection, and we're a nonprofit that works on healthcare access. And so one of the things that we see a lot of is individuals who might already understand what needs they have, or I work with them to kind of identify what health needs are in the community throughout East Baltimore. But there are still a lot of barriers to access, even utilizing things within the system that are already in place. So things like lack of access to dental care that's not covered, or people being slightly over income limits to qualifying for Medicaid, or things like that, or not qualifying for financial assistance.
Right.
Various things are getting into primary care because there are cutoffs to how many Medicaid patients are being taken by large institutions, so they can't get into these places. What kinds of, I guess, large-scale changes do you see that could increase access and kind
Yeah.
of reduce these barriers,
Thank you.
since there are these
Right.
constraints?
There's a wonderful inventory you just provided of a lot of the speed bumps and blocked doors to, people that do this. And so I'm wondering, is there anything hopeful out there that does in fact address some of what she just shared with us? Lisa?
Yes, I mean, I think there is some hope. I think with the Affordable Care Act, a lot of people got access to insurance and got access to primary care services. And so a lot of what we're working on, at least in the Center for Health Equity at Hopkins, is working with primary care systems to redesign the way care is delivered to people who have a lot of social needs, and helping the providers and the nurses and the other staff do a better job of assessing what the social needs are and connecting people with those services, working with community health workers, training people in how to actually work together to identify those resources and connect people to those resources, and actually to go and meet people where they are. So if they can't come to their appointments, having someone go out to their home to meet with them or meet them somewhere in the community. So changing the way primary care is actually delivered and having health systems do a better job of addressing the full patient, not just the medical issue.
Did you want to respond, John?
No.
Oh, did you want to respond? Oh, okay, good. Right here. Hi.
I'm Isadora Schaller. I'm an intern at Martha's Place in Santan, Winchester, but I'm also a student at Hopkins studying sociology. And during this presentation, you've talked a lot about relationships and institutionalized racism. And obviously, Hopkins plays a huge role in Baltimore. It's one of the largest employers in Maryland, but it's also perpetuated a lot of injustices against the Baltimore community, whether it's Henrietta Lacks or research studies with lead in houses. So I guess this is specifically for Dr. Cooper, but how do you navigate serving the Baltimore community, but also being associated with Hopkins?
Okay.
Sorry,
Well,
tricky question.
You want my job.
I know.
That's great.
This is
Yeah.
my daily life.
Yeah.
And hopefully some people in the audience will say that I've
Yeah.
done a good job of this. But, it's like I basically go out there and I try not to be defensive. I acknowledge the things that have gone wrong historically, and I say that I'm there to help change it. And I don't just say it, I actually follow through on things. When people ask us and people in my center as well, if we can come to their church or to their community organization to provide training to people or to teach them or to give them the
Right.
newest research findings, I try to show up. And so if they need training for their staff or they want students or they want us to take young people in and mentor them, we do that. So I think we try to build those relationships and try to overcome those old issues of mistrust.
Right, Garth?
It's hard, I think, sometimes for folks like Lisa and John to praise themselves. So I'll add this because I've watched their careers over the years. One of the things that they do is genuine leadership. And I think it's a lot I've learned from it, and I think it's a lot that others learn. I think when you see Lisa and John in the community, you don't think of them as they're all their many achievements. They're just regular folks. And the way they interact, it's kind of seeing this one-on-one, particularly work with John, seeing how they interact with individuals, inspired me in my own career. So I think for those folks who are younger within the audience, I think the thing to realize is though they have accomplished much, when you
Right.
see them within the community, they're just amazing people.
Let me take this last question right here. Yes, hi.
Well, thanks to all three of you for your leadership and example. I'm Rachel Thornton. I'm a pediatrician at Johns Hopkins. And I wanted to come back to a kernel that came from something John said, which was the idea that in this conversation, I assume at a high level within an institution, talking about access to primary care in the context of insurance reform, somehow there was a particular discussion about the needs of the African American community that didn't seem well aligned with the purpose at hand. Knowing that all of you have been in conversations with people at the highest levels of both health systems, insurance systems, federal systems, with respect to identifying ways to achieve equitable access to care. I'm really curious the message you have for leadership at the highest levels, both within institutions and government, as to kind of where we're missing the boat.
What a perfect last question. Thank you so much. John?
So I think that that's a really good point, that while healthcare systems or public health systems may think about themselves as serving people who are in need, they are also anchors within the institution, and so they're large institutions that employ, they own lots of real estate, they don't pay taxes, right? So what is the responsibility beyond this kind of direct care? But what is the responsibility of citizenship, and is there a responsibility to reckon with the past? So that getting out of the strictly the delivery of healthcare, but also to think about the social determinants of health, not only as an object of research, but as an object of something that a really community-engaged institution can impact by providing opportunity for people in the community. Those are the kinds of conversations that need to happen.
Garth?
For a long time, we as a country have focused on healthcare that occurs in the hospital and the doctor's office. You spend most 1-2 hours out of a year in the hospital, or the rest of the time you spend in your community. What we need to have all of the folks who are in leadership positions, myself and others everywhere, is to continue to figure out how do we build up the community that people live in and exist in every day. And how do we understand how it is that that community influences what's occurring within their home. So I think it's a home to community to health bridge that we need to be able to build up, would be my message.
Lisa?
So this kind of goes against everything that I normally do because I usually, for myself, the reason I do this is because, I care and because I think it's ethically the right thing to do and all of that, but I totally don't use that argument when I'm talking with leadership of health systems, because I've tried that and it didn't seem to really work. So, so I actually focus more on the business case when I present it to them, is that it just doesn't even make sense for you on a business level. You're not going to be able to compete with your peers. You're going to lose reimbursements because everything's moved now to where we're getting reimbursed for taking care of populations and not fee for service. So it just is not a good business model. And if you don't recruit the best and the brightest people, which means you have to go out there and get the most diverse group of people, you're not going to be able to be successful, and you're going to get left behind. So that's the argument I use because it seems to resonate more with them, but that's not the argument that I would normally use.
And that is straight talk from Lisa Cooper. Let me just take a moment. I want to thank John Rich. I want to mention that John at Drexel University has just recently written a book, which sounds great, Wrong Place, Wrong Time, Trauma and Violence in the Lives of Young Black Men. I know many of you are looking at resources, so I want to highlight John at Drexel. Thank Lisa Cooper, of course, at Johns Hopkins for all of her work, and Garth Graham, president of the Aetna Foundation. Thank you so much for your candor and shining a light on this important subject. Really appreciate it.